Hi, everybody, and welcome to the Kansas Business Group on Health's educational webinar, Innovative Strategies for Controlling Pharmacy Costs. We're very glad to have you here today. My name is Matt Tebow. I'm project manager with the Kansas Business Group on Health, and I'm filling in today for our executive director, Shelly Duncan, who was sad she had to miss the program today, but she is out of the office, so we'll be sure to get her the recording of this sure to be fantastic program. So the Kansas Business Group on Health is a nonprofit membership organization that's focused on helping our employer members improve the value of their employee health benefits through improved quality and decreased cost. And there's really no better opportunity for that than pharmaceuticals. And so we're really excited to have a couple of fantastic guest speakers here with us today to talk about what's coming down the pipeline in pharmaceuticals, what we can expect, and then also what are some things that employers can do to try to address the issue of rising healthcare costs. Before I introduce our two speakers, we're going to hear from Kansas Business Group on Health Medical Director, Dr. Justin Moore, and he's going to give us a kickoff introduction on the impact that pharmaceuticals have on employer spend, and then also just in spend in general in the United States. After we hear from Dr. Moore, I'll introduce our two speakers, and at the end of the program, we will have time for questions and question and answers. So if you have any questions as we're going along, feel free to either type those in the chat or we'll also open it up at the end for any questions that you may have. So with that, I'll turn it over to Dr. Moore so he can kick us off.
Thanks, Matt. Let me get my screen shared here and we'll get going. So there are a lot of reasons that healthcare in America is expensive. But according to an analysis about 3 years ago by Ashish Jha now at Brown, there are three big ones. One is that we have really high administrative complexity in this country because we deal with so many insurance plans and so many different payers in general, and we work with so many different kind of subcontractors within that space, including pharmacy benefit managers that we'll talk about. We spend about 4 times as much as Canada, as a nice local example, on administrative expenses, and administration alone accounts for 8% of our healthcare spending. The second reason that the second biggest reason that American healthcare is expensive is that we simply pay our doctors and nurses a lot more than any other country does. Most of that cost, at least on the physician side, is concentrated in surgical subspecialists. For example, primary care physicians in this country make about 50% more than a typical primary care physician would in a Western European country, but say an ophthalmologist or a dermatologist or an orthopedic surgeon makes about 5 times as much as a similar person would in a Western European company. But to the topic of the day, the primary reason that American healthcare is expensive, or at least the biggest reason, is that we just pay a lot more for drugs than any other country does, about 3 times as much as other countries within the OECD. Drugs alone count for about 1/5 of our excess healthcare spending. So if you take nothing else away from the part of the tiny part of today's presentation that I'm giving, I want you to take this away. Americans do not overconsume healthcare. We live under this constant kind of illusion that we do, but compared to other countries, we are really very average consumers of healthcare. And you can see that over time, utilization, which is on the bottom left of this figure, is going down. But over that same period of time, costs for everything, whether it's inpatient costs, drugs, professional fees, whatever, go way up. And prescription drugs are some of the worst offenders in that. And so you see on the right side of the screen that our per capita spending on drugs, at least a couple of years ago when this data came out, was it was pushing 3 times that of comparable countries. Americans account for just short of 5% of the world's population. We account for 27% of global income, so that's great. But we also account for almost 80% of global drug company profits because we pay so much more for these drugs than anyone else in the world does. Now, the drug companies themselves, and I don't mean to throw mud here, but the fact is they will tell you that we are subsidizing the rest of the world's drug development to some extent, and that's why we pay so much. And I will admit that there's probably some truth to that. But the fact of the matter is that research and development don't count for even a fraction of high US drug prices. In this figure, that red line at 100% represents all the money that is spent in the world on research and development for drugs. The gray bars represent revenue. So research and development is well covered. Drug companies are by far the most profitable sector in the US economy. You see both in terms of gross profit, in terms of earnings before interest, taxes, depreciation, and amortization, in net income, et cetera. And within the, even within the medical sphere that is very profitable as a whole, you see on the right side of this figure that pharmaceutical companies are by far the most profitable industry within healthcare itself. They are driven to this not by some kind of mustache twirling evil tendency, but by the simple fact that these are publicly traded companies that are incentivized toward making money for their shareholders. And you can see that drug companies tend to use a lot of buybacks and dividends to drive down their perceived profit at the end of the year. This is propped up by the fact that pharmaceutical companies are astonishingly effective lobbyists. You can see that of the $64 billion that was spent on lobbying in the 20 years between 1999 and 2018, a full 7% of that was spent just by pharmaceutical and health product manufacturers. No other industry, including historically bad actors like, say, tobacco or oil, even come close to that. Pharmaceutical manufacturers swamp everyone else in terms of lobbying power and money spent on lobbying. But to the topic of today, the drug manufacturers themselves are not the only people here that we should really kind of keep an eye on, because pharmacy benefit managers, which we're going to talk about a lot, their hands aren't clean either. They drive costs even higher. And so just as a couple of examples of this, Pfizer, huge international drug company, right? So in 2017, their revenue was $52 billion. Express Scripts, one of the big three PBMs in this country, doubled that. So Express Scripts brought in twice as much money as Pfizer. And a lot of that, as I think you're going to see, was done kind of behind the scenes without a great deal of transparency in terms of how they were getting that money. And ultimately, this cost is passed on to our employees. The mean PBM rebate in 2008 was 10%. By 2019, that had gone up 2.5-fold to 26%. And if you talk about insulin, which is near and dear to my heart, being an endocrinologist by training, the mean rebate was 66%, meaning 66 cents out of every dollar that one of your employees was spending on a drug was going to something other than the cost of the drug. So I hope I have everybody good and riled up by now, and I'll turn it over to Emma and Greg to start sharing hopefully some solutions to all this.
Great.
Awesome. Thank you, Dr. Moore. Oh, thanks, Matt.
Greg, that's okay. I'll introduce you and Emma. That got some great bios. I'd like folks to know who you are. Just real quick, I'll give a bio for our two speakers today. So first up, we have Greg Baker, and Greg is a senior pharmacy consultant. And as a leader of Blue & Company LLC Pharmacy Consulting Group, Greg partners with clients to create and implement innovative pharmacy program solutions that optimize both annual drug costs and patient care. Their approach is unique in the industry, and they take time to learn the needs of each client and create a roadmap detailing how they can gain control of their pharmacy benefits. He has an extensive background in both pharmacy and healthcare management, and Greg is able to bridge the gap between clinical and business issues facing clients to create unique solutions that improve pharmacy value. Also with us today, we have Emma Hu, who is Director of Value-Based Purchasing at the Purchasers Business Group on Health, formerly the Pacific Business Group on Health. Emma focuses on value purchasing, accountability, and quality measurement initiatives at the Purchaser Business Group on Health, including the assessment of accountable care organizations, adoption of common ACO quality and efficiency measures, and expanding use of patient-reported outcome measures. Current activities for them include mental health initiatives, digital health tools assessment, efforts to develop health-related quality of life and pain improvement in oncology care. She has managed joint purchasing and performance measurements initiatives for health plan, pharmacy benefit, retiree, and disease management services on behalf of PBGH members. She has also evaluated and implemented data analytics solutions on behalf of large purchasers to improve healthcare performance reporting. Emma has also authored papers on provider network management and design, consumer-directed health plans, ACOs, and quality reporting requirements for health insurance exchanges. We're very glad to have Greg and Emma here with us today. So without further ado, Greg, I will turn it over to you and Emma.
Okay, thank you very much. And I think you guys can, see we are, we called our presentation Follow the Yellow Brick Road. We completely redid the presentation knowing we were talking to a group from Kansas today. No, I'm kidding. We actually put this together about a year ago, just trying to make it a little bit fun, knowing that when we talk about pharmacy, I think people are usually like, wow, I mean, that's really boring. I work for an accounting firm, so I'm always sensitive to being extra boring with accountants and pharmacists together. But, we try to jazz it up, but make it very informational at the same time. So when we really kind of think about this PBM space, I think there's a lot of things that happen in the background, and that's done by design. I think the PBMs like to hide behind the fact that they say pharma's the bad guy, the manufacturers are raising costs, like we save everybody money. And I fundamentally disagree with that statement. I don't think anybody's clean in this world, but I think the PBMs maybe cause more harm than good. And when we kind of look just not just at the PBMs, but across the industry as a whole, and Emma, I was trying to advance this. There we go. Thank you, ma'am. The manufacturers, they all make kind of a percentage of profit based off of the cost of their drugs. So the higher the drug cost, the more profit they make. Wholesalers are in the same boat. So when you think there's three main wholesalers in the country, and AmerisourceBergen, McKesson, and Cardinal, they make all of their profit as a percentage of what they ship out. So the more money they ship out, the more everything costs, the more money they make. They like that. Then the PBMs, you've got three big PBMs in America, in Express Scripts, Optum, and CVS, and they're in the same boat. So, when you look across the industry, everybody's incentives really are not aligned with that of the plan sponsor, who wants to have a high value offering for their employees, but it's really about how do we save money and drive down costs. The employer's just kind of sitting at the end of that supply chain, having to react to everything that happens upstream to them from manufacturers, wholesalers, and PBMs. So, the whole system is really not set up to align to what you guys really want from your overall standpoint. And then when we look at the industry, what we've really seen happen over the last couple of years is this massive kind of vertical and frankly horizontal consolidation. Like everything's just come together, and you've got the insurer, the PBM, especially pharmacy, and then provider services all within one company. And what these companies are saying is, well, this is great for care, right? Because we can coordinate care, we can see everything. I mean, maybe we haven't seen any of that happen yet, at least from Greg's perspective. But what I have seen is, this black box of transparency or lack of transparency just continues to grow. So when they've got more places to move things around and hide stuff, it gets harder to figure out what they're doing, and then they can make a bunch more profit out of it. So, I think these are really large, very complex organizations, and a lot of things are kind of stacked against employer groups. And we're hoping to give you guys some suggestions to fix that today. I know Dr. Moore hit it pretty adequately at the beginning of this, but pharmacy costs continue to do nothing but go up. We look at the PBM industry, and it really started emerging in the early 1980s. Since the PBM industry came out, and they say they save hundreds of billions of dollars a year, like I can't imagine where we would be without them if these are the trends that have happened since they've been in existence. And, costs do nothing but continue to rise. And, this supply chain that is made up of pharmacy, and you can see like your organization down in that bottom left corner. But it's just like everybody kind of passes money around, and this supply chain is all about making money And then at the end, your organization just kind of has to pay for all the decisions that are made. And you guys really don't get to be part of that decision-making process. So, it's a really convoluted industry and supply chain. And we really think it was designed that way, because the more complex you make it, then people just go like, I don't know what's going on. Like that's fine. It's just kind of cost of doing business and I'll just deal with it. But I think pharmacy is fundamentally changing, and people really need to start paying attention to it and figure out how to bring that differentiated value to your organization. I think the first way to do it, in our opinion, is contract language is a really big deal. And when you look at, some of the contract language out there from an overall PBM standpoint, it's funny. I pulled that top one directly from my company's contract, and I love it. Usually you've got like a brand drug and a generic drug within a contract, right? And a brand drug, of course, costs a lot more than a generic drug. Well, there's a couple different types of generic drugs. So you've got a multi-source generic drug where you got 2 or more manufacturers that make it. So there's competition. And, you can drive a lot of better discounts because you've got 3 or 4 people, or, in some cases up to 12 different manufacturers selling the same product. So you can have them compete against each other, get a really good deal. Well, birth controls are a really good example where there's just usually one manufacturer making a certain product. Now, it's still a generic product, but it's called single source because it just comes from one person. So you still would get a pretty good discount on that. Not quite as good as where there's a bunch of competition, but still a significantly better discount than off a brand drug. Well, what the PBMs like to do is they like to say, hey, we're going to take the single source drug and we're going to move it to the brand category. And then, that helps them get better discounts overall. And then they can just pass along less money to the employer group in their guarantees. And then they keep a bunch of that profit on the back end. But usually you have to kind of dig in the contract language to figure out the game that they're playing. But in our case, they just simply called out single source generics are classified as brand. Well, no, it's a generic. Like, you call it a generic, it's named a generic. So how is it a brand? I have never seen anything that blatant before. And it's just, one line in a 62-page contract. So, our company was a bunch of accountants and they're like, hey, I guess this makes sense to us. So we'll sign the contract and just deal with it and move on. And then there's also within kind of this contract language, there's 4 or 5 different things that they really push on. So I would say if you walk out of this, session here today, taking a couple things away, one of them is around this maximum allowable cost language, or MAC language. MAC lists were really put in place, I would say 6 or 8 years ago, because within a generic contract, if you've seen your contract, you would get an 80 or an 82, 83, say, % discount off a generic drug. So what that means is if that market price, the list price of this drug is $100, and the industry always agrees to those list prices. There's 2 organizations that publish this. So they're like the dictionary. Well, then everybody gets a discount off this price. So the generic discount, again, 80%, just keep it easy, you'd be paying $20. Well, there's a lot of drugs where you've got those 12, 13 different manufacturers making it, where it's like a 99.6% discount. So literally cost pennies for this drug. And the PBMs knew that. So a couple of years ago, they started saying, hey, retailer, let's be honest. You've got 6 cents wrapped up in this. I'm not going to reimburse you $20 because that's what our contract says. So I'm going to remove these really, really cheap drugs from the contract guarantee and put them on what I call a MAC list. And I'm going to tell you that you're going to get no more than $7 reimbursement on this because it's just super cheap. I know it. It's a game you're playing. Well, in the beginning, those MAC lists were good because they were able to take what was a $20 drug and turn it into a $7 drug, and then, of course, save you money. Well, what the PBMs have figured out over time is anything on the MAC list just kind of disappears. It's not part of your discount guarantee. It's not part of anything else they do. So now they're playing all kinds of games where they're going to have one MAC list for a retail pharmacy, and we'll go into it a little bit later to illustrate it. So they pay the pharmacy the $7, but then they have another MAC list for the employer group. They'll charge you $100 because it just doesn't matter on any guarantees. and then they just take everything in the middle as profit. So if you have a contract where you're allowing them to have 2 or 3 or 4 different MAC lists, those games are being played where they're paying the retailer one side, they're charging the employer on the other side, and they're just making a bunch of profit in the middle. But because it's all excluded from any guarantee or kind of like data agreement, like nobody sees it. So it's this really kind of nefarious way that these PBMs have used contract language to simply benefit themselves. Specialty drugs are another big deal, and there's no great answer for specialty because the industry can't even agree on what a specialty drug is. So the industry can agree what a brand drug is and what a generic drug is. Everybody defines their own specialty lists. So you really want to try to ask questions to say, what's a specialty drug? How is it defined? What are my rebates on it? What are my discounts on it? Because if they can start saying like, you don't get a rebate on specialty drugs at retail. Well, why? Because the PBM's getting paid a rebate for it. So why wouldn't the plan sponsor end up getting a portion of that money back? So there's a lot of this contract language that just goes on and on. And, these contracts are long and crazy, again, totally by design, but the language really matters. There's market check language where you can say, I want to make sure that I'm getting a good rate. But then if they have all of these requirements to do a market check that are completely onerous and nobody could really actually do them. So they say like, well, sorry, you didn't find a similar group that was exactly like yourself with the exact same drug mix as you have and the exact same utilization and the exact same geography. So therefore it's not the same. So your market check is just void and we're not going to change anything. And they put that in contracts and people sign it. So then that way for the 3-year term of the contract, they can pretty much do whatever they want. And you can't kind of change any of those things as market dynamics continue to change because you can't find somebody that meets the definition of a similar organization within the market check. So, that contract language is very important. And what we also see, I would say the second takeaway in a PBMs, and we see a lot of consultants doing this too, they talk about the word rebate. So, if you got to get 100% of your rebates, that's the big thing. Well, if you really follow the money to see where PBMs make their money, well, in 2015, yes, they were making a significant percentage of their profit in rebates, but in this plan year, it's almost dwindled to nothing. So, the game that PBMs are playing, and I think consultants in general are allowing this to kind of propagate, is this rebate story. So all they've done is in 2015, if they were giving, the pharma manufacturer was giving the PBM, say $1,000 for a drug, the PBM would have in the contract, okay, for this $1,000, I'm going to call 800 of it a rebate and $200 of it these additional fees. So like an admin fee, a data sharing fee, or something like that. Well, now in 2021, all they've done is said that same $1,000 that they get from pharma, just in the contract, they're saying, well, I just want to call 500 of it a rebate. And now I've added 7 more fees that I need to get paid for. So the PBM's getting kind of the same money back in rebates, but they just defined it differently in their contract. So therefore they pass less through to the plan sponsor. And then like in public, they're like, oh, fine, I'll give you 100% of rebates, like twist my arm, like I'll whatever, like you got such a great deal out of me. Now I'm not making any money because you get all rebates. But they're making even more in the back end because it's just how they've termed the revenue coming in. And we can point that out directly in how fees have grown. So, in 2015 to 2021, they doubled their profit pool in fees. But then the other really big place they're making their money is on their specialty pharmacies. So these PBMs love having all their carve-in specialty pharmacy options. Because between specialty and fees, they went from only making about 1/3 of their profit there to making 2/3 of their profit just in those 2 categories. So, we really like to say, like, if you follow the money, you can really understand the games that are being played and then hopefully defend yourself against those. So within any contract language, you really want to think about rebates. If it says rebates, you're probably getting played. It really needs to say manufacturer revenue because you should be getting the lion's share of the revenue they're getting from pharma and not just what they decide to define as rebates within that contract. And we look at, this whole area is like there's transparency and control. And if you have transparency and if you have control, you're going to end up with an overall better deal. Like SHRM really kind of talks about when negotiating, pharmacy benefit managers, should ask for transparency. And then, there was a survey that was done, and people who think at least that their PBM is more transparent are happier than when they're less transparent. So transparency has a big impact on things. And it's kind of funny, in this world, nobody knows how much they're going to pay for their drugs when they show up at the pharmacy. You as the employer really don't know how much you're going to get charged. You can't really get great data to show it. You don't know what your rebates are going to be. You really don't know what your overall spend is going to be. So there's just like no transparency at all. But like when I came here to Blue, it was funny. We were talking to my boss one time, and he was like talking about his house and like something that they did on the weekend. And I'm like, well, I wonder where this guy lives. So I went online and found his house, and I know exactly what he paid for it. And I know how much taxes and by the way, this is not my boss's house. He would kill me if I did that. But like, long story short, like you can go online and find out where they live, how much they pay, so how is there this level of transparency out there in the real estate market? And yet within the pharmacy world, nobody seems to know anything. And everybody likes to play stupid because the less anybody knows, the more profit that can be made. So again, it's just this whole thing by design. But we do think that there's a better way to get transparency within contracts. It's something that you can ask for. It's something that should be achieved. And if you don't have transparency, you're never going to have control because they're just going to be able to continue to do things on the back end that nobody can see. And, we had talked about kind of that profit being made off the specialty side for these pharmacies. And we kind of dig in claims data for our employers to find it. Now, this is one of the more egregious things that we found, but this is one of the large 3 PBMs. The client of ours was a hospital. So the hospital has their own pharmacy, their own outpatient pharmacy, but the PBM still tries to push a lot of business to the PBM's own pharmacy. And so in this claims data for this one drug, you can see that this is the exact same drug. So each drug has this 11-digit NDC number. So it's for this drug by this manufacturer with this package size. And then that's what determines payment. So it's the exact same drug, exact same strength, exact same quantity. But when it goes to the employer's own hospital pharmacy, the hospital was charged about $190 for this drug. Every time the drug went through the specialty pharmacy, it was almost $4,000. Well, this goes back to that single source, multi-source generic concept, because when the PBM would recognize that drug going through the hospital, they recognized it as a generic product. But then when it went through its own specialty pharmacy, all of a sudden it was a brand product because it was a specialty drug in their world, and it went through our specialty pharmacy. So therefore they could just charge whatever they wanted. And they know that at the end of each month, they're sending out invoices with like thousands of line items in there that don't mean much to anybody. So the PBMs just start charging whatever they want for this stuff, and nobody ever looks. And, maybe the one time in 10, you've got a consultant or a group that's sophisticated enough to really start digging in. And then they show this, it's just, oh, my bad. I'm sorry. Like, we must have coded that wrong. We'll see if we can get that fixed for you, it is absolutely by design. It's just, there's no coincidence that every time it goes through the PBM's own pharmacy, it's $4,000. And anytime it goes anywhere else, it's 20 times less. So, there are definitely things that are happening on the back end that people really need to watch out for. And then from that rebate standpoint, sorry, let me get to the next slide. This is, we pulled this is all publicly available information. You can Google through a lot of like either retired teachers or state organizations, their PBM contracts that are out there. So we pulled this off of one of those contracts. This is an Express Scripts contract, but it's really illustrative of what we see. And as we talked about earlier, that $1,000, where it used to be $800 in 2015 were a rebate and $200 in fees. Now it's more kind of $500 in rebate, $500 in fees. And like Express Scripts is just my favorite. So where they first call out, in its capacity as a PBM company, Express Scripts may receive compensation from manufacturers for performance of various programs, including formulary compliance, clinical, therapy management, educational, inflation protection, medical management, cost containment, discount programs, and sale events. So now they've got 9 fees because they're just so busy. They do so much work as the PBM, they need to get paid for those fees. And oh, by the way, this compensation is not part of your formulary rebates or associated with admin fees. So Express Scripts may happen to realize some positive margin from all of this. So, they put it in their contracts and they call it out. Well, the interesting thing is, if you really think, let's just dig into one of these fees that they talk about, and it's that inflationary protection program. And this is kind of fascinating to me. And transparency, I will say, my wife, I love her to death. We're both pharmacists. She works for a PBM. She signs rebate deals on behalf of that PBM. So I always kind of joke that she's like the heart of the devil. And I've clarified this with her. I'm not calling her the devil. She's just the heart that keeps it alive. But it's just terrible. And so it was probably, I don't know if everybody remembers, in early 2019, the Trump administration came out with this big announcement that 32 or 36 drug manufacturers had signed this deal that they're not going to increase their prices more than 5%. Now, it all fell apart, but that's what they came to, and these manufacturers signed up for it. And we were sitting at dinner that night. It's 6:30 and her phone rings, and she's like, her work phone, and it never rings after 5 ever. So, it was huge anomaly. So she gets up and looks at it. It's the president of the company. And she's like, oh my gosh, I got to take this. So she goes in the other room and she's talking for a couple minutes. We've got 3 kids in high school. So we're just sitting there eating well, this is weird. So she comes back, acts like nothing's wrong. I kind of heard some of what they said. But, so anyhow, we finished dinner, kids go to bed. And I'm like, so, hey, I got to ask about that call. It sounded like he was mad prices aren't going up. Is that right? And she's like, well, yeah. I'm like, so wait a second. So you, as your group, you want prices to go up more? And she's like, well, yeah. So and different groups call it different things. Their group calls it price protection. ESI calls it inflationary protection programs. But what the concept is when the PBM signs a deal with these pharma manufacturers for this box, say, they would say, so the PBM says, I will pay a 5% increase every year on this box. That's it. I'm capping it. I won't pay you more. So if you increase prices 10%, manufacturer, I'm only going to pay you that 5% increase. But then what happens on your side, the employer side, that 10% increase gets passed to you. So you're paying the whole thing. Well, the PBM's only paying up to the 5% increase. So that last 5% is just all profit to them. They keep it. So again, talk about misaligned incentives. So the system is rigged. They want prices to really go up higher and higher and higher because they're protected at a certain level. And if it goes above that level, that drives their profit. And this announcement in 2019 came early in the plan year. Well, they had budgeted for that entire year all this extra profit, and it would have killed their financials had that prices not increased over the course of the year. So, I mean, it's just this perverse system. But, we were trying to figure out a better way to illustrate it. And again, ESI kind of did our job for us. Love those guys some days. But Express Scripts sued a pharmaceutical manufacturer in federal court March of 2018. Kaleo was the group. And by the way, some manufacturers aren't as bad as others. Kaleo is just as bad. So this is kind of like the devil fighting itself in this scenario. I'm not saying anybody's good or bad. They're both bad. But it just really kind of proves the point about why contract definitions matter, and when rebates are what you're given from the PBM, how much money is really being left on the table just for them to keep. So in this lawsuit, if you look at it, it is like reading a CIA Black Ops document. It's almost completely redacted. Now, there's a bunch of it that's not redacted, though, at the same time. And I don't know how this isn't redacted compared to what is. But it's interesting. If you read through it enough, it talks about in April of 2016, Express Scripts invoiced Kaleo $5.1 million under their rebate agreement for this one drug, just one drug. And of that, $7,125 was for formulary rebates, which they give to the employer groups. $5 million was for this price protection, and another $130,000 was admin fees. So if you think back to the last slide in the ESI contract, where they call out, here's all our fees, including, inflationary price protection programs, whatever they want to call it, admin fees, those things. You get the formulary rebate of $7,100. They're going to keep the $5 million because of all the work that they do on the back end. It's like, really, guys? So we, through what you could see in the course of this contract, we pulled out where they defined formulary rebates, and there was about 3 total months of data between their commercial and their Medicare business. But just in those 3 months, they defined all of $26,800 as rebates. There is somehow $363,000 in admin fees and almost $8.5 million in these price protection programs. Because if you notice, on February 1st, the price of this drug went from a $937 list price to a $4,700 list price. So like Express Scripts was loving life because they were price protected. Well, Kaleo, the drug manufacturer, probably was starting to get mad because they weren't making money. So now all of a sudden you got both of them fighting with each other because, hey, I increased the price of the drug $500 and you get all the profit PBM. Somehow that wasn't fair. And I mean, we don't need to talk about how messed up the whole situation is, but again, I mean, Express Scripts probably was due the $8.5 million just for those 3 months. And that's fine. But the fact is, on the back end, they were just keeping all of it for profit. It's not like they were doing it to help buy down expenses or make drugs more affordable for you or your members. It was simply a greed thing for them. So, again, when you think about this whole rebate language, there's a lot of dirt being played. And thankfully, through, certain public filings and, federal court documents, you can see some of that play out. Now, the last thing I want to talk about before I kick it to Emma is the other thing that's kind of important, and we talked about it a little bit in that example where the PBM specialty pharmacy was billing almost $4,000. And then if it went through the other hospital pharmacy, it was like $190. So the claims piece is important to look at. Again, we looked at our own company's claims. So when I got here and we started working with them and, teaching our leadership team about PBMs and why they matter and how the contract language matters. But then really you do need to look at your claims on a consistent basis to see that if contract terms are being met. Like, just one very easy and interesting thing we found was in our contract, it called out for a drug that's filled with a day supply of 83 days or less. Our group got a 17.75% discount off that brand drug. Now, if the days of supply was 84 or more, we would have got a 20% discount. Now, inflated a little bit, but just to keep it easy, the average list price of a brand drug right now in America is about $1,000. So 20% discount, you're going to pay $800. A 17.75% discount, you're going to pay about $825. So, per every brand script, that number starts adding up a little bit. Well, when we started looking at our claims, every single claim, no matter what the days of supply was a 17.75% discount. Never was there a 20% discount. So, again, and we were filling a lot of 90-day scripts. I mean, that was costing our organization, and we're not very big, hundreds of thousands of dollars, just that one little piece. And then again, when we pointed out to the PBM, they were like, oh, really? That's happening? Oh, our mistake. We must have screwed something up in the coding on the back end. We'll go ahead and get that fixed now. But again, if somebody's not really looking at these things on a consistent basis, it's allowing those games to be played on the back end. And it's just really important to watch over these PBM shoulders because we're consistently seeing ways that that's played. And I think with some of the work Emma and PBGH have done through their waste-free formulary is another good explanation of that. So Emma, do you want to talk us through that, please?
Sure. Thanks, Greg. So PBGH worked with Integrity Pharmaceutical Advisors and Johns Hopkins to conduct this work where we collected data from our employers and ran it through an analysis for select drugs that we know there are much lower cost alternatives without a reduction in quality. And, where some actions that employers can definitely take from the get-go is look at these categories of drugs that are displayed on the slide. Multi-source drugs, that involve, high-cost branded when generic products are available. This is also the case where when a brand drug goes to generic, there are often protections in place around the pricing during that interim period. And employers should be cognizant of, where there are opportunities to make these lower cost options available to their members. Another category where we saw some of the most egregious pricing, and these are detailed in the report, and on our website, we also have a calculator, a spreadsheet that you can use to plug in your own utilization experience to calculate what some of the potential savings might look like. These are combo drugs, where, two or more of the active ingredients are combined into a single pill that then goes under a new filing as a specific brand that then costs substantially more than the individual ingredients. Now, some of the pharma companies or PBMs will argue that in combination, there's better compliance than if patients are asked to take individual pills. That may be the case, at the margins, but at the end of the day, the cost factor is just humongous in terms of some of these combo drugs. We also see drugs where an alternative over the counter is available. And then also Me Too drugs, where a small modification takes place to increase the patent life of a particular brand drug that allows separate marketing for that revised drug that really is not materially affecting the clinical impact and the information that then communicates through some of the advertising, suggests that there are differences, but these Me Too drugs create, another layer that employers need to sift through, both in their data and understanding of some of the incentives that go into the marketing and the payments that go back to the PBMs, because oftentimes the PBMs may also be receiving a large rebate to promote some of these items and to keep them available in their formulary as a preferred option. Some of the examples, I think these are, some Duexis is, very commonly cited, where, the main difference is the addition of ibuprofen, which, many of you know is available, via over the counter, as Advil or some of these other common drugs that are available in the pharmacy. And the cost differences, as you can see, are dramatic, for what is basically a $10 over the counter bottle of drugs. So, the examples are many, unfortunately, and we really need to, hold PBMs feet to the fire, as well as health plans. And more recently, after this report was published, we saw presentations by some of the carriers like Cigna talking about their efforts to reduce the availability of these drugs in their formulary. And, our question was, well, what were they doing in your formulary in the first place? So, there's definitely a lot of oversight that is needed, and, independent review by pharmacists can really benefit organizations in understanding what's going on, because, these are constantly changing, and it really takes a lot of oversight to manage both the plan and PBM relationships. Another one of our projects that we undertook in collaboration with Pfizer is to look at biosimilars. Biosimilars are new drugs that are entering the market that are designed to be similar to other medications that are coming through the biologically manufactured pipelines. And many of the parallels are drawn towards generic drugs relative to traditional drugs. However, biosimilars, just by nature of how they're manufactured, may be slightly different from batch to batch. However, their clinical efficacy is still identified as the target interaction and the clinical effect that is part of the design. So a lot of organizations don't fully understand how biosimilars can be optimized and used in lieu of some of the high cost medical specialty drugs. And for a number of years, there were just a handful of these drugs in the marketplace. And so it wasn't really on anybody's radar. But the pipeline for these biosimilars is huge, and there's a tremendous opportunity both for employers as well as plans in better managing access. And the important thing too is to understand that these are commonly billed through the medical claim, so they don't necessarily show up in the pharmacy direct spend. The challenges are tremendous, both in influencing the referral and prescription process. Providers, have long been paid, through a buy and bill formula where CMS Medicare allows a percentage addition to the cost of the drug. And so they make more when the drug costs more. And at the outset, oftentimes these biosimilars are priced very similarly to the origin product. But over time, the goal is to increase competition in the marketplace so that there is opportunity to see differential pricing and ultimately, at the end of the day, save money for consumers, especially as they face high deductible plans or other co-insurance options that create significant cost sharing in some of these services. Just to give you an idea of what's in the pipeline, for a long time, we saw a few of the cancer biosimilars come into play. We also are seeing it in the rheumatoid arthritis area, and that's actually been one of the areas where we've seen the most success. But the pipeline is growing, and there are tremendous opportunities as we look at these going forward. One of the huge ones that is coming down the pipeline is the biosimilar for Humira that is manufactured by Amgen. And in that instance, this is already available in Europe, but a contractual agreement for the United States led to a delayed release of the biosimilar to 2023. But even as these become available, it's a long road to hoe to change some of the provider prescription behaviors and some of the underlying incentives that are tied to how we pay for these drugs. One of the examples that I mentioned that has been very successful is with respect to Inflectra, which is a treatment for rheumatoid arthritis. This example is from Kaiser Permanente, which of course is a unique provider in that they have a common EMR platform using Epic so that they can build these referral processes into their EMR and decision support for their providers. But behind the scenes, they convene their pharmacy and therapeutics committee to review some of the options and made the recommendation to provide a preferred referral for use of Inflectra over some of the prior drugs that were available. And unlike the typical environment in the marketplace, whether it's IPAs, independent physician associations, or solo practices, you don't have this infrastructure behind the drug referral decision-making. And in the case of Kaiser, they built in decision support to help drive changes in behavior among their providers. And of course, the providers are employed through Kaiser, and their overall incentives are aligned in a way that is different than the general marketplace, where the providers don't make more money by referring patients to higher cost treatments. And at the end of the day, the savings show up in the employer spend and the overall trending. So there's a huge opportunity as these biosimilars enter into the marketplace to promote competition and better access for consumers. But one of the challenges we find is education. We conducted the survey among employers to understand, what they knew about biosimilars. And, these are some of our own members, as well as through a collaboration with some of the other coalitions in the marketplace, where we interviewed a number of large employers. And some of these were jumbo employers, and some of these were between 10,000 and 100,000. They use a multitude of carriers, as you see on the list on the left, some of the national carriers, as well as TPAs that are geographically concentrated, and some of the blues, as well as some of the emerging programs like Collective Health, where they aggregate different vendors to support employers with the idea of presenting best-in-class management in each. But within, these organizations, the PBMs vary greatly. Some of these, as Greg noted in his early slide, are subsidiaries where companies are pretty much vertically integrated, and others are standalone contracts. So the experience reflects a pretty broad array of carriers. And what we found was a significant gap in understanding and knowledge about biosimilars. And where we found significant differences, where there was an in-house medical director or clinical pharmaceutical expertise. But this is only the case in about a third of the companies. And even their self-rating of their knowledge, we identified in many cases that the organizations that had this clinical expertise had a good knowledge of what was coming down the pipeline, as well as the opportunity, where many just had a passing awareness that biosimilars had entered the marketplace, and that they would create lower cost, high quality options for their members. So at the end of the day, what employers can do with their contracting language is recognize that there's definitely opportunities to motivate questions among consumers about options by integrating access into their contracts and their benefit design. Oftentimes, if an employer waits for a PBM to make a change or a health plan to make a change, it's really driven by rebates or other incentives, as opposed to low cost options for the consumer. A key thing is just to understand what the opportunity is, to analyze the spend that is occurring primarily on the medical side. And one of the big challenges here is that these services are often billed with J codes that may have some overlapping use, and are hard to aggregate. As Medicare comes out with a new code, providers may switch to the Medicare standard. At the end of the day, what you want to ask for are billings by the NDC code, so that you can really understand the unique use of these drugs and where there may be options to introduce biosimilars. Oftentimes we hear back from providers or health plans, that it's really hard to bill the NDC code. But in fact, what we have found is that as health plans start mandating this, voila, the NDC codes start getting populated. We actually saw this happen in the Medicaid space first. And, we said to some of our carrier partners, well, if providers are doing this for Medicaid, why can't you collect this information? And some carriers have been much more aggressive than others. United, for example, instituted a requirement in their Medicare Advantage plans, and they're now also encouraging this billing across the board, so that they're getting better data to track this utilization. And then, if you can't get this data, I think the opportunities are huge in terms of incorporating it into your RFPs as you select TPAs or partners in managing this area. Some of the other, opportunities, include, identifying sites of service, bringing, expertise in to analyze the data. I won't go through these in detail just in the interest of time, but some of the, key opportunities to relate to changing the site of care. This was highlighted especially during this COVID pandemic, where patients really felt uncomfortable going to outpatient hospital clinics. And by necessity, many organizations then explored referrals to infusion clinics or even home-based services. And there are oftentimes savings that can be identified through the change in site of care. In some instances, we've had employers successfully adopt changes in their coverage policy and also their site of care. And this is an example from Albertsons, where they saved a tremendous amount of money by switching the use of some of the drugs in their formulary. And they're unique in that they're also a supplier from a retail basis, but they had a lot of internal expertise that was brought to bear. Greg, back to you.
Awesome, great information, Emma. And we do have a couple more slides, but just in the interest of time too, want to see if there's questions that we can answer. I know we've already provided a lot of information for you all to absorb. So any questions that Emma and I can answer?
Greg, I did have a question. You mentioned when looking at your PBM contracts to follow the money to see, how they're getting paid and the different avenues they're getting paid through. How do you suggest an employer do that? Is it just going through the contracts with a fine-tooth comb, or how is that something they rely on their consultant with, or how would an employer follow the money?
Yeah, thank you, Matt. And unfortunately, I don't think there's a great answer, because it's like every day the game changes and we find out something new and different. I would say, consultants are hopefully a good place to start, but I don't think that all consulting groups are created equal. We've seen a lot of groups where they're making more money off the PBM than they're making off their clients. So, again, as we think about aligned incentives, they're not always there. I would make sure that you talk with your consultant to ensure that there's not issues with their responses back, because sometimes there are. But it is really, there's rebates that matter, there's drug definitions that matter, all of those buckets kind of matter, because if you leave one thing open, one door open for the PBM, we always see them go through that door, and it's just a profit opportunity for them and a major expense for you and your organization. So it's really important to make sure that you get that contract language right. During a contract turn is always the best time to do it, because once that contract is signed, usually for the next 3 years, that's what you're dealing with, and it's really hard to get out of those contracts.
I would add to just having that independence of review. We have been working with Greg on these projects, and it really brings a fresh perspective than when some of our employers have traditional relationships with some of the big brokerage or benefit consulting houses, many of whom run their own PBM purchasing pools. And so the information that some of our employers were getting was not fully objective. And what we learned over the years is that many of those consulting houses that run their own purchasing pools, they're making a lot of money, and their consultants are actually sharing in that profit, and sometimes getting a big bonus when they bring a new client into that purchasing pool. So they're not exactly as independent as folks might think, and they do tend to look at things through like a particular lens that is commonly used within their own firm, and often aren't tracking some of the changes in the marketplace as closely as some of the independent specialty consultants. We've worked with Greg, we worked with IPA in this space, and the it was very enlightening.
Hi, are there any pass-through PBMs like Drexy or Southern Scripts that will sort of save us all this work?
I'm torn on that. I'm not, beyond the ones you mentioned, we look at a lot of PBMs. We have found a lot of them. There's one or two things that they do in the background to kind of play a game. Now, like a Southern Scripts, a Navitus, they're better than the big three, but they're not really true pass-through when we really start digging under the hood for them. We do hope that there's some products that are going to be coming to market, and I know PBGH is working with some folks on this as well to say like how do you just bring one that's straight pass through? They're only making a per script fee, and you really can track the data on everything else that's out there. But I would say as we're sitting here today with the folks in the market, it's more who's not as bad. And there is a, not as bad, but we have not found one that really does what they say in that true pass through, no spread pricing, full control, all audit rights, that kind of thing. So it's just
who are the three least bad PBM?
The three least bad. I mean, Southern Scripts is not terrible, but they have a lot of these like international programs and things like that I just fundamentally don't agree with. So, if you just look at them for a true PBM offering, I don't think they're bad. I know PBGH is working to bring a, product to market that's, I think it'd be really good, very transparent, no spread pricing, no pass through. That's not here yet, but it should be here kind of as around a 1/1/22 start. So something to keep watching out for. Navitus, from an overall standpoint, I don't think they're bad, but they've got really kind of antiquated technology. Their reporting isn't spectacular. So there are kind of, I think, some transparency issues. We think that they're doing some weird things with their MAC lists. And again, if you're doing something with your MAC list, I think there's a lot of open opportunities to, have leakage within kind of that money going to your pharmacy benefit. So those would be my three kind of best guesses right now.
Thanks.
You're welcome.
All right, any other, I see we're at our time here. Any other questions for either Greg or Emma? Thank you both for your great presentation.
You're welcome.
Okay, well, hearing no other questions, Emma, Greg, is it okay if we share these slides after this presentation?
Emma, that's okay with me. Are you okay with that?
Yes, absolutely.
Okay. Well, thank you again, both, for your presentation today. There was so much great information. If anybody out in the audience today wants more information about some pharmacy solutions that you can use or investigate for your employee population, let us know at Kansas Business Group on Health, and we can help direct you to some resources that we have and that we know of. So if you'd like to learn more, please contact myself, Shelley, or Dr. Moore. Greg, Emma, thank you again. We really appreciate your time and sharing your expertise, and thank you everybody for attending.